Oh my God, you made a grand entrance. I love it. I pulled back the curtains. Good morning. I'm going to try that next time. That's so funny. Look what I have. I have my special cup.
Oh, good.
Looky, looky.
Oh, yes, great.
This is my menopause method cup. You can't see it really, but
No, when did you receive it?
About a year and a half ago, to be honest with you. And I use it downstairs all the time, so I had to run down and get it. Yes, in honor of our interview today. Good morning, Dr. Rosa.
Good morning.
How are you doing?
Fabulous.
Fabulous. Excellent. Amazing. Cool. Okay. So we have some good questions, as we always do.
All righty.
Yeah, but I'm going to ask you one first. That actually your amazing son Joshua had brought up to me because it's very timely right now, and that is in regards to the hormone estriol and how it. You know the question I'm going to ask, right?
I'm smelling it.
Okay. I'm sending it through the ether.
Okay. Telepathy will work. I'll answer it telepathically, and the audience certainly is tuned in telepathically. Well, why don't we go old school with it? Why don't you just go ahead and ask it? We'll go old school.
Okay, old school works. We like old school. Estriol, and how does it relate to our immune systems? I'm hearing that it's very helpful for our immune systems. Am I correct?
Yes. Well, it begins with this. Number one, the ovary puts out a bunch of hormones. And it puts out 3 active estrogens. And the one that's most well known and the most potent estrogen is estradiol. And the second most potent estrogen is estrone. It's about 80% as potent as estradiol.
Right.
And then estriol is about 12% as potent as estradiol. So estriol is a weaker estrogen. Or as Dr. Jonathan Wright has said, I'm going to give you a sneak preview here about estriol. Its weakness is its strength. Estriol. Now, very interestingly, the ovary puts out more estriol than the sum of estrone and estradiol. When we do analysis, the 24-hour urine analysis of ovarian hormones, we see that there's about twice as much or even a little more estrone as there is estradiol. So estrone is more prevalent than estradiol. And estriol is more prevalent than the sum of both of them. Depending on what study you look at, the one that was done in 1970 by an oncologist, 1969, late 1960s, Dr. Henry Lemon, estriol is about 1.3 times as prevalent as the sum of estrone and estradiol.
That's crazy, but okay.
And I was funded to do a revisit of that study about 5 years ago by a wonderful lab named Metametrics, now owned by Genova. And we tested, we originally interviewed 600 nursing students between the ages of 19 and 29. And we got about 90 samples of mid-luteal estrogens. And what we saw in our data was that there was 1.3 times as much, 1.1 times as much estriol as there was the sum of estrone and estradiol.
Interesting.
Late 1960s, Dr. Lemon finds 1.3 times as much on average.
Wow.
5 years ago, we find 1.1 times as much. Estriol is the sum of estrone and estradiol. Now, that's just a background to estriol. And I shouldn't have probably gone into the weeds that deeply about it. There is more things I have to say about it, but I'd like to go right to the immune system because that was your question. Here's an interesting thing that's been noted about women who have multiple sclerosis. One thing multiple sclerosis is known for is it waxes and wanes. Some people who have multiple sclerosis go for a significant period of time with no symptoms whatsoever. And then they get an attack. They get a recurrence, it's called. And they get plenty of symptoms. And then sometimes those symptoms can disappear. They go into what we call remission. That's well known about patients who have multiple sclerosis. It can go into remission or it can go into recurrence. Recurrence is that active stage with lots of symptoms, multiple sclerosis. One thing that's been noted is especially in the third trimester, the last 3 months of pregnancy, women who have multiple sclerosis often are at the very best they ever get. They often go into remission and have the very best time that they have is in the third trimester of pregnancy. One of the things that stands out about the third trimester pregnancy is the estriol levels are at their absolute highest that they ever get. So they're already more prevalent in a young menstruating woman. And in the third trimester of pregnancy, the estriol levels get as high as they ever get. In other words, when women with multiple sclerosis go into the third trimester of pregnancy with these tremendously high estriol levels, they most often go into a wonderful remission. The multiple sclerosis symptoms disappear. So this has been capitalized on. In fact, an old friend of mine wrote a book about the use of estriol with multiple sclerosis. So we know multiple sclerosis being an immune system involved illness in which the immune system is attacking the nervous system. We know that estriol has some kind of wonderful modulating effect. Now, is this the total cure? Well, no, these illnesses that are strong illnesses, they have a complexity to them. But estriol has been used to treat women with autoimmune illnesses. And by my goodness gracious, any woman who has any kind of autoimmune illness should at least do a trial of being treated with estriol.
I mean, would like rheumatoid arthritis be considered an autoimmune?
It is.
And could one conceivably ask one's doctor if one could use estriol?
Yes, and I'd recommend going into doing a search for in the internet, because there are articles about this. There are scientific articles in PubMed that describe the benefit of estriol in autoimmune illnesses.
It's very interesting.
So yes, that would be something, you know, with any illness, you get good ideas on how to address it. And the proof's in the pudding. But estriol would be something I would definitely try with anyone with an autoimmune illness.
Very, very interesting. It really is. And especially in these days, for sure, which, you know, we don't need to go there. But nevertheless,
I want to go a little further with it.
Yes, please.
What these illnesses are named autoimmune, it's sort of a funny name.
Mm-hmm.
I sort of see it as automatic immune, you know, like, well, automatic, what do you mean? It suggests that it's automatic or something. I don't know. Or it's self-immune. The immune system is attacking self. But we find in so many cases, there's a provocateur of that immune system. For example, something is provoking the patient's immune system to attack itself.
Right.
And I want to give you the classic example because it's going to lead us, for anyone with autoimmune illness, into how to search for and deal with what in the heck is provoking your own immune system to attack your own body. Well, one of the most classic cases I ever heard of this is there was a patient in Tennessee. This is like 40 years ago. I heard about this, who went to their general practitioner, and the general practitioner gave them a medication because of suspected intestinal parasites, gave them a medication called metronidazole, otherwise known as Flagyl, for some kind of dysentery. So weeks later, the patient goes back to the doctor and said, "Doctor, I know you gave me this medicine because you thought there was something going on in my intestine. I wasn't sure why you did it. That wasn't the thing that was so prominent to me. But is Flagyl a rheumatoid arthritis medicine?"
Right.
Because, doctor, for the first time in 20 years, I have no rheumatoid arthritis pain.
Isn't that something?
Is Flagyl an arthritis medicine? Well, that captured a lot of attention and garnered a lot of interest. Like, what in the heck is going on there? That Flagyl quieted down rheumatoid arthritis. And here was what's believed about it. That when you look under the microscope at a parasite like an amoeba, what you're really looking at is a single cell. So I ask you, Carolyn Shapiro, how different are you and I from an amoeba? We're multi-celled, an amoeba is single-celled. It's wonderful how almost similar the amoeba single cells looks to some of our single cells. And that amoeba has a cell membrane. It's like its skin.
Yes.
And that cell membrane under an electron microscope has a great deal of complexity to it.
Yes.
Let's say it looks like this, the cell surface of the amoeba.
Right.
So what happens when our immune system is floating around and discovers an amoeba? Here comes the immune system. Whoa, what is this thing over here? This is foreign. This isn't us. Geez, let's grok it. And the immune system will form a template of it. And this thing is known as an antigen, this amoeba cell surface. And the immune system will form something that is like a mirror image or an exact template of it. And this thing's called an antibody. Antigen, antibody. Amoeba, cell surface, immune system, grab a hold there. Wow, we've got a template. And this antibody goes off to the rest of the immune system, I'm traveling to the rest of the immune system and saying, hey, folks, we're being attacked by the mirror image of this. Let's form a lot of antibodies and let's go tie up this sucker. So jillions of antibodies are formed, and they go and find anything that looks like this, and they attack it. They tie up that amoeba and they get rid of it. That's good.
Sorry. Animal Crossing.
So here's this amoeba, and it's a single cell. What if the antibodies that form to the amoeba go around and identify some single cells in our body that sort of look like the surface of the amoeba? We're talking phospholipids, we're talking proteins. They have a molecular configuration and an actual structure. And that's how autoimmunity is felt to function. That the antibodies that went to form that, to capture that germ had a cell surface and a configuration that looked like the cell surface of some of our cells. So thyroiditis is classic. Hashimoto's thyroiditis. Why is the immune system attacking the thyroid gland? Or why is the immune system attacking the joints in rheumatoid arthritis? Or why is the immune system attacking the nervous system, as in multiple sclerosis, autoimmune illnesses? Because something provoked our own immune system, and that provocateur had enough similarity to it, to the cells in our body, and the immune system that really mobilized to attack our own, to attack that germ or that parasite, cross-reacted with our own cells because of a cell similarity, a cell surface similarity. So autoimmune, although it implies a mystery to it, actually has some kind of provocateur. Things happen for a reason. Now, there's lots of ways to interpret autoimmune illnesses. And I don't want to make it sound ever so simple. Just for example, some people have thyroiditis, their thyroid gland. And there are people who think that the immune system mysteriously went after this piece of equipment because it's related to a certain speaking, languaging, communicating. So people who are failing to communicate could get an alert called an illness right here. And the purpose of illness is to get us to ask the question, what the heck's going on here?
Right.
And so if you ask the question, I got autoimmune thyroiditis, I'm getting attacked in my throat, what's the real answer? Maybe there's an element of failure to communicate the truth to yourself and to the others. So medicine's got a certain complexity to it, as does life. Maybe some of you have noticed that.
No.
So I don't want to oversimplify it and say it's a simple occurrence that our immune system meets up with the cell surface configuration of the phospholipids and the proteins on a cell surface, and that's how it all happens. No. Life and medicine is far more complex than that. But here's my point. When someone has an autoimmune illness, you don't want to just treat with estriol.
Yes, which was going to be my question.
Estriol deficiency is not the reason
that
the person had trouble.
Right.
That doesn't mean I wouldn't hesitate to treat with estriol to calm things down. It's always wonderful to calm down an excessive immune response. It's wonderful to do it, especially with something so kind and safe and beneficial as estriol. Such a friendly molecule it is.
It's a warm, yeah.
But I wanted to go further because I don't want to oversimplify something. And when someone has an autoimmune illness, go out and just find some kind of quieted down thing. You want to get to the bottom of these things. Common provocateurs of the immune system, inappropriate provocations, come from molecules that slip into our body for all kinds of reasons. So I gave you an example of a molecule, actually an organism, an amoeba that slipped into our intestinal tract from drinking some kind of crazy water or food that had the amoeba in it. Well, there's other ways for molecules to slip into our body. We can swallow molecules that can be provocative. Oh my God. Ordinarily, those molecules are contained within the intestinal tract, and those foreign molecules are never allowed to slip into the body. So it turns out that our friendly, wonderful bread, that previously known as the staff of life, I say previously known as the staff of life,
right.
It contains this very provocative molecule called gluten. Gluten, I always thought that was well named. As a kid in school, we made something called paper mache.
Right.
We took white flour, we added water, and the thing turned to rock. That's because of the gluten molecule. So it turns out that the gluten molecule in wheat-containing products and others can be provocative. It's a big molecule. It's tough to handle for a lot of people. Well, no problem. If it's tough to handle, it should never make it out of the intestinal tract into the bloodstream.
Right.
The intestinal barrier should
Yeah.
prevent funky molecules from escaping into the bloodstream. Well, unfortunately, people have a lot of compromise to that barrier. That barrier, which should be really stringently specific, rigorously specific, to only allow certain size molecules through, and certain acceptable molecules, can get messed up, and the holes can get too large. The microscopic holes can get too large and allow to pass through the intestinal lining molecules that are too big and have no business getting in our bloodstream. This is called leaky gut. And there's
Something
reason.
I'm familiar with these days very well.
Yeah, look at the territory you're floating around in
Oh,
now. You're
yeah.
swimming, you're dog paddling in, you're racing in. And
Broken bones
so
in bodies, yeah.
when someone has an autoimmune illness, we do a very thorough search as to what is provoking that immune system. And gluten happens to be one of those molecules that's so common. A lot of people, you see a lot of gluten-free stuff.
Yeah.
Anyone who's goes to health food stores, for example, or even supermarkets these days, see gluten-free this, gluten-free that. Why are they doing that? Why are they producing so much gluten-free stuff? Because in this time in our history, when there's a lot of health compromises for a lot of reasons, we got to clean up our act. And there's a lot of people who just don't tolerate gluten. And what can gluten do? It can provoke an immune response. So people who get exposed to who have a leaky gut and some gluten leaks through, they can have an autoimmune response. So someone with an autoimmune illness, we don't just go looking for amoebas. We go looking for any kind of molecule that can provoke and can slip into the body and have no business doing there and elicit an immune response that can be cross-reactive with our own tissues. And that's what autoimmunity is.
Thank you. Thank you. And I'm going to in the next interview, because I want to get to these questions. But it just brings up the thought to me of xenoestrogens and how, we can get a mimicker.
Yeah, I mean, we're opening up Pandora's box.
I know.
What other provocative molecules can slip into our body? Well, let's probably not go there today.
Right.
Because you usually have a list of questions for me.
I do, and I have them here.
Yeah, Pandora's box got opened, and xenoestrogens would be in a different category altogether than molecules capable of provoking the immune system and causing,
yes, of course,
causing immune attack, self-attack. So
anyway, oh my God, yes. Okay, well, thank you so much. I think that this is amazing. Interesting, right up my alley for sure. I hope up other people's alleys as well. So this is a question.
Can I interrupt us? We just got an interesting and easy question from Sean.
No way, easy question.
In the chat that I see.
Yes.
Because it's an easy question, I'd like to go. Sean asked, why is the progesterone 100 milligrams orally I was prescribed causing me to be groggy all day? Because you're on overdose. Because progesterone, like any molecule, you got to get the dose right. You got to get within the therapeutic window. That means there could be too little of anything you take, or there could be too much of anything you take. To get the right response, you got to be in the therapeutic window. And what progesterone is the great calmer. And so people who don't have progesterone get anti-calm called anxiety, or they don't sleep. So we always suggest when we go to oral progesterone that a woman take her progesterone at night. But if we overdose her, she's not only going to get calm during the night, she's going to wake up groggy like she had been taking an overdose of a sleeping pill. So Sean, do not give up on progesterone. You just probably have got an overdose. And here's how we do it. We give when we always start with topical progesterone. But when we need more, we're not getting the sleep effect that we want, we'll switch to oral progesterone. Because progesterone, unlike estrogen and testosterone, progesterone is safe to be taken orally. And what we start with is we give women 30 capsules of 25 milligram progesterone and 30 capsules of 50 milligram progesterone. And we have a woman start with 50 milligrams, most women. Some women will even have them start with 25 milligrams. But most women, we have them start with 50 milligrams of progesterone when they go to sleep. And if they don't wake up groggy, and if they had some sleep benefit, that's great. We'll still increase it to 75 milligrams. And if they sleep even better and they don't wake up groggy, at 75 milligrams, that's great. We'll go up to 100. And if we give them 100 milligrams, then this time they wake up groggy the next day, we'll know that 100 milligrams was too much. We'll back down to 75. 75 will be their dose. That is called dose determination by titration. Download. Carolyn's made our book available for no charge on ins and outs of menopause. Happy
right there at the top. Yep.
You'll learn all about that. But I think we should go back to the questions that people have submitted before.
They keep coming and they're fabulous, and it's so hard to not just chomp into them.
Chomp into them.
Yeah, I like to chomp them. And so I'm reading everybody's and I'm welcoming everybody in. Thank you for being here. And we'll get to these questions. We do. This question, Dr. Rosensweet, as well as I do, as long as we've been doing this, comes up all the time. And I asked it myself too. I understand it now better, but women continue to ask, and often, as I did, what the exact number is that they should be at when taking estrogen so that they know that they're optimal. They want a number. So can you please tell us what this actual number is?
Yes.
Thank you.
However, what I've done is I went into the medical literature to find out what's the right amount of estrogen. And the medical literature has some lovely, great, perfect information, and I cite that information in our book and certainly in our professional training program. And how do we define the right amount? Well, for one thing, there is no exact right amount of anything when you're talking about human beings, because we vary so much as to individual need, individual sensitivity, individual absorption, individual preference. When you put those four alone together, you have a wide variety, a range of what the number is. So it isn't a single number, it's a range. Or shall I put it this way? Some women, for example, some young women, they need this much estrogen to come out of their ovary to have a normal menstrual cycle. And if they don't have it that much, they fall below that much, they don't get a normal menstrual cycle. They don't menstruate. They need this much estrogen. But other women, they need this much estrogen to have a normal menstrual cycle. Women vary enormously, as men do. And, when you look at the range for blood tests, when you test young women of estradiol, for example, it's a wide range. It's not a narrow range. It's a wide range because there's this thing called human individuality. So it's no problem at all. Once you get hip to individualizing somebody, you just take them through a process to individualize them. And so what we have done is the medical science there's medical studies that really help us define, what's the right amount for a woman in menopause? Because that's really what we're looking for, is what's the right amount of estrogen, for example, for a woman in menopause. How we evaluate that is there's two potent estrogens, as I was mentioning early. There's estradiol. That's the most potent. We assign it a potency of 1. And estrone, that's pretty potent. It's about, we assign it a potency of 0.8 or 80%. It's 80% as a potent. So when we look at potency of estrogens, we take those two into account and we add up. For example, in 24-hour urine, we look at the estradiol plus estrone. These are the most potent estrogens. We call them the total potent estrogens. And we want to know what's too much and what's too little. Well, here's some studies that were done to define what's too little. If a woman doesn't have enough total potent estrogens, she's going to lose her bones. She's going to develop osteopenia, then osteoporosis. She's going to lose minerals and protein from bone. Her bones are going to get less dense, and ultimately are going to put her vulnerable to fracture. So young women have strong bones.
Dem bone.
And when them bones don't have enough estrogen floating around near them, they lose their density, their strength. They become osteopenic, osteoporotic, and they're vulnerable to fracture. So we know the numbers. We know how much estrogen a woman needs at least to protect those bones. And interestingly enough, it's about the same amount it takes to protect the vagina. A woman who does not have sufficient estrogen is going to get vaginal atrophy. She'll experience it as vaginal dryness, and if she's having intercourse, she will have pain on intercourse. And anytime she has a pelvic exam, any experienced examiner will look at her vagina and they'll be able to tell, oh, that's a healthy vagina. Or they'll be able to say, oh, that vagina has undergone atrophy. It's gotten really thin, really delicate. So we know how much estrogen you must have to prevent vaginal atrophy. And it turns out that amount is enough to protect the bones. And that's what we define as the lower limit on 24-hour urine. When we add up the total potent estrogens, estrone plus estradiol, we know what that number is. A woman needs to be excreting at least 8 micrograms of the sum of estrone and estradiol to protect her bones in her vagina. And if she's not excreting at least 8 micrograms, that's the low end of things. Let's talk about the high end of things. We think it's important that a woman not have so much estrogen that she stimulates breast glandular cells. Like a young woman, once a month, she prepares in her normal menstrual cycle, she prepares for possible pregnancy and breastfeeding right there at the beginning in the normal menstrual cycle.
Right.
She actually produces additional breast glandular cells in preparation for a possible implantation and breastfeeding ultimately 9 months later. Additional breast glandular cells, breast glandular cell proliferation. How does that happen? By mitosis. You get cell division once a month. That's an interesting process, cell division. That's a very vulnerable time in the genetic story. These chromosomes are dividing, and it's a very, cell division is a very important time. We want cell division to go really accurately.
Yeah.
To go really accurately. We don't want any mutations to take place. But at any rate, once a month, she's preparing. It takes a certain amount of estrogen for her to actually develop an endometrial lining, to receive a fertilized sperm, and also to develop the first stages of breast glandular cell proliferation. It takes a certain amount of estrogen. In some women, like I was illustrating earlier, it takes at least this much. If they don't get that much, they fall below that much, they are going to not have enough to form an endometrial lining, thus they won't menstruate. And if they fall below, they're not going to have enough to prepare their breasts for breast glandular cell proliferation. Whereas other women, they need this much for the same process. So that's a range.
So, I'm sorry. I just wanted to say, like, hypothetically, me, Carolyn Shapiro, says, gee, I'm at 122. You need to be at 122. That's a completely incorrect statement, right?
Yeah.
Yeah.
Yeah, it's a wide range.
Right.
But I am defining the upper limit. Like, what's too much?
Mm-hmm.
Well, the upper limit is normal for a young woman.
Right.
She's preparing her breasts for possible breastfeeding, and young women can feel this. A lot of young women will say, gee, during the course of my month, I get breast tenderness, I get breast fullness. Yeah, part of that fullness is caused by actual breast glandular cell proliferation, extra cells. Well, in a menopause woman, we believe that we don't want monthly breast glandular cell proliferation. And a wonderful case is made by a gynecologist. I think he's at Princeton. His name is Alan Altman. He's written an editorial on this. We cite this in the book, Happy Healthy Hormones.
Please download that book.
Dr. Altman says, once a month mitosis in a menopausal woman, a young woman with a very vigorous, robust immune system, capable of identifying mutations and getting rid of those cells better. But a woman in midlife, we don't want to see mitosis. So Dr. Altman suggests, and we ascribe to this, we don't want so much estrogen as to get breast glandular cell proliferation once a month. So if this is a young woman, she needs some young women need this much, some young women need this much, or somewhere in between there. That's how much we think a young woman needs for estrogen to be healthy, and have a period, and possibly get pregnant, and possibly breastfeed. That much.
Right.
Women, bam, right below that. This 8 micrograms that I defined earlier, look, that's below that. In fact, we don't want them to have even this much, because in these young women, they can get breast glandular cell proliferation with this much. So we define that upper limit as 14. So we want a menopausal woman to have the sum of her potent estrogens to be between 8 and 14 at a 24-hour urine hormone test. Younger women, they go from 13.8 to much higher, up to 24. They get a normal menstrual cycle and normal breast glandular cell proliferation, bam, in that range. Menopausal women, we want them below that. And, lo and behold, if you have 8 micrograms of the sum of estrone and estradiol in a 24-hour urine, you're going to protect your bones, and you are going to protect your vagina. Now,
sorry.
It's more complex.
A
lot of women have cognitive challenge. They're not thinking as clearly. In fact, it's well known that some women can progress to dementia. And one reason that they do is insufficient estrogen. In fact, it's one of the most common reasons a woman loses her cognition is through loss of estrogen. And when we replenish estrogen in a younger woman who's getting in menopause, but she's getting cognitively challenged, we replenish her estrogen, her brain comes back. Thank you very much, they say universally. Oh my God, I'm thinking clearly again.
Right.
Notice in my description of here's young women,
right.
Here's menopausal women. We want to treat menopausal women in this zone. I did not define that enough to protect the brain. I didn't do it because we know there's a certain percentage of women that will do just fine with this amount, that they'll recover their brain function if they're having cognitive challenge with this amount, but not all women. So there are exceptions, and we respect those exceptions. There are some women who are going to need a lot more estrogen to prevent dementia.
Right, and
to restore decent cognitive function. So there are exceptions, and they're rare, but they exist. So I never want to leave these out. So although I've defined the proper amount of estrogen in a 24-hour urine to be between 8 micrograms per 24 hours and 14 micrograms per 24 hours, there are some women that need a lot more. So
Right.
we will go above 14 if we are not getting cognitive restoration. And in those women who have a family history of dementia, man, we're going to push it. And we will take them as high in estrogen as we need. There are cases where we give them so much estrogen their period comes back. That's not a practice that I do other than rarely, but when cognition is at stake and preventing dementia is at stake, yeah, we'll take it to the period's coming back. Now that's a robust amount of estrogen. In order to bring a period back, you need between 3 and 8 times the amount of estrogen that a young woman's ovary produces. It isn't a simple matter of youthful levels. You got to go 3 to 8 times the upper limit of normal of estrogen to get that period to sustain or come back. Will we do that? Yes, we will. Because if cognition is at stake, we'll do it. However, under ordinary circumstances, and there are protocols out there that are recommending these robust levels of estrogens just on a day. Well, I don't believe in that. I don't accept that. I've challenged the originator of that in person, up close in person. It was a rather fiery confrontation because I said that I don't think we should be encouraging breast glandular cell proliferation in young women and getting that period back. It takes 3 to 8 times the upper limit of normal of young women. I'm sorry, in menopausal women. I don't think we should be doing that. And bottom line is risk for breast cancer. Well, breast cancer is very complex. And it isn't a matter of just estrogen and estrogen levels. Cancer is very complex. How in the heck do you create that cancer? So in a woman that we need robust levels of estrogens, we do what we do with all women that we're treating in menopause. We monitor the breasts because there are wonderful monitoring techniques called mammogram. I didn't say thermography. I love thermography, but not for detecting breast cancer. No way.
Right.
I love it for other reasons, but mammography, radiologic techniques, I know that this challenges some people, but my God, I'm a medical doctor. I've seen breast cancer picked up on routine mammogram. And boy, when you pick up a breast cancer early, the cure rate's around 100%. It's close to 100%. You pick up a breast cancer early on, I'm repeating myself. And what's capable of doing that? Mammography. And thermography, unfortunately, is not. NOT. You might challenge me on that. Sure, challenge me.
I won't.
Mammography.
Oh, no.
Mammography is not perfect. Yet, I'm a medical doctor. I've seen cases of actual women that on routine mammograms, they picked up a small breast cancer, and the treatment is, it's still not the easiest thing in the world, but you treat it early, you get a cure. That's pretty cool.
It's pretty amazing.
So anyway, I know I've drifted a little bit here, but I'm not going to declare that estrogen causes breast cancer.
Right.
No way. And I invite people to read the book Estrogen Matters by an oncologist, Avram Blooming, and his partner, Carol Tavris, for this complex subject. But meanwhile, what do you need? Back to the original question. You need to test by 24-hour urine in a woman that you're treating with hormones. And in order to protect the vagina and bones, you need at least 8 micrograms of the sum of estrone and estradiol.
Right. And remember, that's micrograms, not milligrams.
That's
micrograms.
Right, per 24 hours. And we like to go as high as 14. That would be the upper limit that we commonly accept. If you go above 14, you put a woman into possible breast glandular cell proliferation. We're not saying that's an adverse event. We're not saying that to have some breast glandular cell proliferation is bad. We are saying we want to we've developed a method that our bottom line is, how do we bring risk for adverse consequences, like, for
Right.
example, breast cancer, how do we bring it as close to zero as we can possibly get it? We can't get it to zero. We're all at risk for all kinds of stuff, including cancers. Men, I'm a man, prostate cancer. Women, you're at risk, increased risk for breast cancer. There's reasons why men and women are at increased risk for this. We
Right.
can't get it to zero, but we're very scrupulous. So in almost all instances, we're aiming for between 8 and 14 micrograms of excretion of the sum of estradiol plus estrone per 24 hours. That's our goal. And will we go above it? You betcha. If cognition is at risk, we will go above it, and we'll do what we always do. We, in the menopause method, we have a protocol that calls for appropriate frequency of repetition of mammograms, whether it's 1 year or every 5 years or whatever it is. We individualize that as well. So, yeah, there's all kinds of ways to address anything in any given individual.
Right.
8 to 14. You want to know the number? It's 8 to 14
micrograms. Okay. So, with the menopause method, so much of what you say almost all the time is that individualization. Each woman is different. So if she's having this symptom, that symptom, the other symptom, you're going to go on that journey with her to try and figure out, yes, of course, why she's having anxiety. If the estrogen isn't high enough, if it's too low, progesterone, testosterone, DHEA, all of that. So it's all individualized per woman because each of us is so different.
The medical term for that, Carolyn, is the whole kit and caboodle.
I just read that in my medical book. It was the strangest thing. I think it's on my test question. Or test, period. One of the questions.
Can you define caboodle?
Caboodle? Well, I can only do it if the kit is involved.
Yes, the whole kit and caboodle.
the whole toolbox. Yes. I mean, we have such amazing questions that are to me on my right, and I've got these other ones in front of me. On that same line, there is a woman who wrote in, and she's been writing in a lot, bless her, and she is asking if there is such a thing because she can't seem to get her estrogen up no matter what, like cream, oil, this, that, the other. And she wanted to know if there is an bioidentical solid estrogen pill that she could take.
There is.
Yep. Okay. Thank you.
And we ordinarily recommend that a woman take estrogen topically, applied to the skin or the mucous membrane, such as the vagina. We prefer the skin, and it's very unusual. I run into it so rarely that, for example, the organic oils that our pharmacies dispense, our hormones in, our estrogens in, our biased in. It's almost never that we run into a case where the absorption doesn't occur.
Right.
Now, sometimes we really got to play with the strength. Sometimes we got to double or triple the strength. A woman, anyone who doesn't know their numbers, won't be fazed by that at all. I just increase the strength, and they get it in there. So it is almost even now. We've got a couple cases that we're dealing with, a couple patients that we're dealing with, that it looks like absorption's an issue, and we're trying to figure out how to do it. But I have never not solved one of those topically. I have, in 25 years of treating women in menopause, I have written one prescription for oral estrogen, and it was for my own mother. She wouldn't let me treat her or get near her medically. Her son, the doctor, she loved that her son was a doctor. She was of a different generation. when she was alive. But eventually as she was starting to get cognitive decline, she let me treat her, and topical application was just more than she could figure out.
Right.
Even though we've developed in the menopause method something called menopause method elder. It's a combination formulation to make it easy for the elderly. That was too much for her. So I gave her oral estradiol, bioidentical estradiol, orally. Now, to the questioner, I'd say, gee, I wonder if someone has really hunkered down and given you the proper dosages of estrogens, because I have yet to run into a case, although we've got a few pending now that are pretty challenging, where a woman cannot get estrogen in topically. It absorbs beautifully, and sometimes we have to double or triple the strength. So what? The reason that we don't favor oral estrogen is there are rare but complications that can occur. Because what we know about estrogen given orally, as opposed to estrogen given topically, is that it can stimulate the development of hepatic, that's liver, proteins. And we don't want that. And one of the things that can happen is it can provoke an increased blood propensity to coagulate.
Right.
Blood coagulating? No, don't love it. Blood is delicately poised between being able to coagulate if you get a cut, and yet not having coagulating too easy, so you get an intravascular clot. So it's delicately poised. Well, we can push that coagulation mechanisms towards not coagulating. That's what anticoagulants are about. That's what, for example, aspirin's about, or omega-3 fats, or vitamin C, or vitamin E. They will all push towards less coagulability, or we can push someone in the other direction. We don't want to, but we can. Infections will push someone towards enhanced coagulability. Oral estrogen will push women towards enhanced coagulability, and the other hepatic proteins are inflammatory proteins. So oral estrogen will push a woman towards inflammation. Enhanced oral estrogens push a woman towards increased coagulability and inflammation. Now, where did we first learn this? Birth control pill. Inside of a birth control pill, there's two hormones. One of them is almost, not totally, but almost a bioidentical estrogen called ethinyl estradiol. Estradiol's in there. And there was a certain small number, but they definitely exist, women who took the birth control pill and they got thrombophlebitis and a clot in their lower extremities.
Right.
They did enhance coagulation. Gosh, some of those women, that clot broke loose and traveled to the lungs, and they got a pulmonary embolus. That's life-threatening. There.
Yeah.
So we learned that, so many millions of women went on birth control pills. The incidence is small, but it is present. So we are, again, in the menopause method, we are so rigorous is that if we can, how close to zero can we bring risk of any kind? That's why we do not favor oral estrogens.
Yeah.
We don't want to provoke, even if it's one woman out of 1,000. Well, we're treating thousands of women, so we don't want to have that one woman pop up if it can be easily avoided by topical, so we go topical. Coagulation is a whole story.
Yes.
We have a 12-hour training program for professionals online. Coagulation is one of those chapters because there's ways to evaluate whether you have an increased propensity to coagulate. So, every topic that these questions that you get every week, Carolyn, I wish it was so much fun to answer that simple progesterone overdose question. But some of these questions, especially why do we not recommend oral estrogens? So before you go to oral estrogens, I'm going to raise the possibility that someone hasn't tried everything.
Well, I think that you don't miss a beat, and I know that about you. And she did say, I'm in such and such a city, and I really have to be my own advocate with the physicians that I have to work with here. And she does. She's a bright woman, and she's tried a lot. And so, yeah, you called it. You absolutely called it.
You can increase the strength of the topicals, and you don't even know, nobody knows. Physicians very often don't know the numbers.
Right.
What do? You increase the milligrams per milliliter, and you'll absorb this stuff in your skin, because compounding pharmacists have got great ways to get it to go into your skin.
Yes.
They've been doing it for over 50 years. They know it really well.
Yes.
So I am going to say that if you can, and I know it's disheartening to hear that in 2021, we're still very primitive in the world of treating women in menopause. And I do understand that women have to advocate for yourself, and that's why I wrote that book. You have to become you're not going to become an active participation in your cardiology program. The cardiologists know enough to do it really well with you. If you fracture a bone,
right,
you're not going to have to be an active participant and sit there and tell your orthopedic surgeon how to do it.
Right. You're not going to be doing your own hemorrhoidectomy or, DNC.
These specialists, they have been so beautifully trained and they've done, by the time they get to you, they've done hundreds of cases in most instances. You're not going to have to tell them, now, why don't you try taking my hemorrhoid out from the right side in this.
Right, exactly.
Here, I suggest you use these particular surgical tools. You're not going to have to do this. Yeah, exactly. In the world of menopause, you still do. Unless you do the menopause method. And there are physicians and nurse practitioners and compounding pharmacists out there that actually do know a lot and have a lot of experience. You got to find one of those. That's your job. This particular Facebook Live always comes down to the same thing. Always. Your job, women, is to go hunting and shopping until you find a healthcare provider that you can trust and who's been trained in this and really knows what they're doing and has experience. And now with telemedicine,
I'm just going to say that, yeah.
Any state that you're in, there's someone in your state who's taken on, and you do not have to see your menopause specialist in person. No way. It all can be done by telemedicine. The menopause method, we do everything by telemedicine. So anyway, oh my God.
I know it is. It is. We're both going to turn into pumpkins if we don't go away. The coach is coming. Well, you know what? It's been a really interesting interview. We didn't get to all of our questions, and it's totally okay because it was fascinating to me, as it always is. Lots of great questions. And again, I have my work cut out for me. I do. And thank you, Dr. Rosensweet, so much. Always.
You're so welcome, Carolyn Shapiro.
Yeah, huh? I'm so happy that everybody was up here. Always appreciate you, Dr. R. Always going to wish you a fabulous weekend. Wish everybody a fabulous weekend. You guys know where to get with me, and I'll get back to you. And Dr. R, we're going to talk to you on Tuesday.
All right.
I think it's Labor Day weekend, right?
Oh, yes, it is.
It is, but that doesn't affect us on Tuesday.
That's right.
That's right.
All right, everybody.
Safe, happy.
Good to see you, and until next time.
Indeed. Hasta.